Assalamu alaikum wa rahmatullahi wa barakatuh. Today our lecture is abnormal uterine bleeding. Our objectives will be to understand the symptoms and etiology of abnormal uterine bleeding, what are the terminology used for it, and to know the causes and symptoms of heavy menstrual bleeding and the appropriate investigations and management of it. To know the abnormal, we should know first the normal. During the reproductive years, the menstrual bleeding normally occurs each 24 to 38 days. The normal duration of a bleeding is 4.5 to 8 days. This is the duration of the bleeding, and the amount of the flow is less than 80 milliliter of blood. The disorders of the menstrual bleeding now, which are termed as abnormal uterine bleeding, are one of the most common reasons for women to attend seeking medical help. This abnormal uterine bleeding pattern can range from amenorrhea to life-threatening hemorrhage. There are several classification systems for the abnormal bleeding. Some of the terminologies that you should know include heavy menstrual bleeding, intermenstrual bleeding والذي يقصد به النزف الذي يحدث ما بين الدورات التي تأتي في وقتها الطبيعي ولكن يوجد نزف ما بين الدورات. Postcoital bleeding, postmenopausal bleeding. This bleeding occurs more than 1 year after cessation of period. So we should exclude endometrial pathology or vaginal atrophy. Bleeding of endometrial origin. This is a diagnosis of exclusion. It means that we exclude other causes and then we say the endometrium itself is the cause of the bleeding. This term has replaced the dysfunctional uterine bleeding, which was the older term. بعض المصطلحات تستخدم سابقا وممكن أنه في بعض المستشفيات في عندما تداوم بالعيادات الخارجية ممكن ما بعض الأطباء يستخدمها. تشمل polymenorrhea, which are abnormally frequent menses, menorrhagia, metrorrhagia, menometrorrhagia, and dysfunctional uterine bleeding. Now, the terminology which is used to describe the bleeding patterns will be including the following terms to describe it. Frequency of the menses, regularity of the menses, duration of the blood, and the volume of monthly blood loss. يعني إذا مثلا we said frequent, regular, heavy mens, it means the duration is less than 24 days. Heavy, it means that the blood is more than 18 milliliter. Regular, the variation is within 2 to 20 days. طبعا variation يؤخذ from cycle to cycle over 12 months. وهنا راح نجي إلى نقطة مهمة. بالنسبة للفيميلز الطبيعيين لا يشترط أن تكون المنسترول سايكل في وقت محدد. لا يشترط أن يكون مثلا each second of a month لأن هناك variation. بمعنى أنه إذا البيشنت جاءت وهي تعتقد أنه she has abnormal menstrual cycle, by history when we review we see it is usually within the normal variation pattern. The newer classification system, which is the palm coin, takes into account there are two different influences on the abnormal uterine bleeding. هنا راح يقسم لنا causes behind the abnormal uterine bleeding إلى structural اللي هي ممكن أنه نجدها عن طريق الفحص ممكن investigation، والكوين بارت واللي هو عادة ما يكون functional disorder قسم من عندها يعني نصل إلى بعد exclusion of other causes. البالم it means polyps, adenomyosis, fibroids, malignancy and hyperplasia. While the coin, it is related to coagulopathy, ovulatory dysfunction, endometrial cause اللي كنا نسميه bleeding of endometrial origin. iatrogenic مثلا البيشنت وضع لها intrauterine contraceptive device سبب لها heavy menstrual bleeding، أو أنه تأخذ anticoagulant drug and had be abnormal menstrual bleeding and not yet classified واللي احنا ما ممكن نعرف الكوز إلهم. In our lecture, we will focus mainly on heavy menstrual bleeding because it may present as an emergency. 20 to 30% of women of their reproductive age, they will suffer from this. The etiology, it is the same as the palm coin. When you face a patient, you will start assessing her by history. We should first check, is it acute or chronic heavy menstrual bleeding? In the younger women, it is important to question whether this heavy menstrual bleeding started at menarche, because this is much less likely to be associated with pathology. The regularity of the cycle is important as this can be associated with early puberty or perimenopause. يعني نقصد أنه في السنين الأولى بعد الميناركي وفي آخر سنين عندما تكون المرأة في فترة حول المينوبوز ممكن تحدث بعض التغيرات في نمط الدورة بحيث لا تكون شهرية، تكون متباعدة، تكون أحيانا heavy. This is related to the dysfunction in the ovaries themselves. وعندما نأخذ الهيستوري لابد أن نسأل عن symptoms أخرى. These may be suggestive of the pathology. إذا كان heavy menstrual bleeding مصحوب ب irregular bleeding, intermenstrual bleeding or postcoital bleeding لازم نخلي في فكرنا possibility of endometrial, cervical polyp or other cervical abnormality. وعندما يكون هناك excessive bruising, history of postpartum hemorrhage, excessive post-operative bleeding يعني تلاحظون bleeding tendency otherwhere, we should think of coagulation disorders which will be present in about 20% of the patient having heavy menstrual bleeding. إذا كان هناك unusual vaginal discharge, we think of PID. If there are urinary symptoms, abdominal fullness, we may think of fibroids. Weight changes, skin changes, you should put in mind thyroid disease. Those patients who present with acute heavy menstrual bleeding, we should check if they are hemodynamically stable, if there was dizziness, loss of consciousness, and we should take full history regarding the medications. We check the vital signs and then we do examination. And we should put in mind that early pregnancy and its complications should be always ruled as a cause of abnormal uterine bleeding in women of the reproductive age. بما معنى إذا اجتنا امرأة في reproductive age عندها amenorrhea، أول شيء نبحث هل هناك حمل أو لا. إذا كان irregular spotting bleeding لازم نستثني abnormal bleeding. The following investigation can be useful to guide for a clinician to assess the etiology, and later we start the management. We do pregnancy tests, full blood count, collocation screen, pelvic ultrasound, thyroid function test, high vaginal and endocervical swabs, biopsies may be necessary, which include cervical and endometrial biopsy. When do we need to take endometrial biopsy? If there is postmenopausal bleeding with endometrial thickness on transvaginal ultrasound of more than 4 mm, if there is heavy menstrual bleeding over the age of 45, heavy menstrual bleeding with intermenstrual bleeding, treatment failure, and prior to ablative technique واللي حنتحدث عنها لاحقا. How can we get endometrial sample? Either in the outpatient can be taken by pipal or vibra accurate. تكون العملية سهلة في العيادة الخارجية. نستخدم هذه الأدوات اللي هي ممكن تعمل إما عن طريق سكشن أو ككيوريت ناعم تأخذ النعينة من الاندومتريوم. وممكن نستخدم outpatient hysteroscopy with guided biopsy. طبعا hysteroscope أي شيء بكلمة سكوب يعني بمنظار. hysteroscope هو منظار للرحم. متى نستخدم الهيستروسكوب? If the endometrium biopsy attempts fails in the outpatient, if the sample is insufficient, if the transvaginal ultrasound is inconclusive, if there is abnormality on the transvaginal ultrasound and we think that it is amenable to treatment such as endometrial polyp. If the patient fails to tolerate any outpatient procedure, then we need to dilate the cervix and we need to do this under GA associated with a treatment. This is a hysteroscope set that shows you. Here is the light source that connects to the electricity source. This is the eyepiece, and here is the biopsy forceps. Now, how can we manage a heavy menstrual bleeding? It will depend, is it acute or chronic? And when we want to select the type or the appropriate treatment, we should put in our mind the patient preference, risk and benefit, contraceptive requirement. لأنه ممكن نستخدم contraceptive pills لعلاج الهيفي menstrual bleeding، وبنفس الوقت راح نغطي الcontraception need للبيشنت. past medical history، ممكن يكون أكو contra indication للهرمونال ثيرابي، أو إنه إحنا فكرنا نعمل سيرجري ولكن هي البيشنت she's unfit for anesthesia. كذلك لازم نعرف الباست surgical history. فرضا مريضة عمرها 48 سنة وعندها عملية سابقة for myomectomy، الآن أصبح الأفضل أنه نذهب إلى hysterectomy ونتجنب إعادة المايومكتومي. الآن management of acute excessive bleeding. We will need hospitalization and transfusion if there is severe anemia and the HB is equal to or less than 7 gram per deciliter. Surgical approaches will be usually reserved for the patient who does not respond to the medical treatment. There are many hormonal regimes which have been used in acute heavy bleeding, and only 3 therapies, in fact, are reliably effective, which include using the methoxyprogesterone acetate موجود بالmarkets under the name of Provera, 20 milligram each 8 hours for 7 days and then once daily for 21 days. Or we use contraceptive pills, which are combined types, a tab each 8 hours for 7 days, and then we use it one pill per day for 21 days. The other regime which can be used is methoxyprogesterone acetate, 20 milligram each 8 hours for 3 days, then followed by the intramuscular injection of depot methoxyprogesterone. If the patient does not respond to the initial therapy within 12 to 24 hours, surgery is indicated, and in acute condition, dilatation and curettage is performed to remove the remaining endometrium. لأنه إحنا السورس of bleeding بالمنس it is from the endometrium. الانdometrium يتكون من basal layer و superficial layer. When shedding starts and it doesn't stop, we will do curettage in order to remove the remaining endometrium and we stop it. أو ممكن we use balloon which can be placed within the uterine cavity to tamponate the bleeding vessels حتى نضغط عليها ونوقف النزيف. Selective embolization of the uterine blood vessels، وهذا طبعا يصير عن طريق catheterization and used by the effort of an interventional radiologist in order to stop bleeding. طبعا the last result will be hysterectomy. After the initial episode have been resolved وإحنا هنا نتعامل acute bleeding, we should make our effort to stop recurrence and we should look for any specific cause and treat it. Now, what if the patient is having chronic and not not acute heavy menstrual bleeding? The therapies will be directed to the underlying, whether structural or medical problem. Despite the investigation that we do, we may find no pathology. And in this case, as we have mentioned before, the diagnosis will be bleeding of endometrial origin. Why this occurs? Many theories have put behind the pathogenesis. Some suggested disordered endometrial prostaglandin production. Prostaglandins, some of them have constrictive effect on the blood vessel, others cause dilatation. If there is imbalance and the blood vessel will be keeping on to be dilated, this will lead to increase in the bleeding. Other abnormalities that have been suggested are abnormal endometrial vascular development. Medical treatment options for the chronic heavy menstrual bleeding will include either we normalize the prostaglandins using ibuprofen or naproxen. This therapy will reduce the blood loss by 20 to 30%, and it can be combined with hormonal therapy. Other target is to use antifibrinolytic therapy, which act to stabilize the clots using tranexamic acid. This will reduce the blood loss by 40%, and they should not be combined with estrogen containing medication, and they may increase the risk of having thrombotic events and CVA. Other target is to coordinate the endometrial sloughing. It is best used for patients who are having anovulation, مثلا في polycystic ovary. We use progesterone to support the low progesterone levels, and this will emulate the luteal phase and to prevent the unopposed estrogenic stimulation of the endometrium. Endometrial suppression is another policy. This will cause lighter bleeding, or we may create amenorrhea using progesterone only contraceptive pills or medroxyprogesterone acetate. We may use extended cycle or contraceptive pills. Depot medroxyprogesterone acetate intramuscular injection may be used, and levonorgestrel intrauterine system. The levonorgestrel intrauterine system, which releases 20 microgram of levonorgestrel per 24 hours، هذا كأنه هو لولب، بس لولب الناس تسميه اللولب الهرموني because it releases hormones. And when we use also medroxyprogesterone injection, it will may induce amenorrhea in significant percentage of women with longer use. Regarding the intrauterine system, which is the levonorgestrel releasing, it is one of the most effective medical treatment of idiopathic heavy menstrual bleeding, and it can prevent about one half of women having hysterectomy. The use of extended cycle contraception or uninterrupted use of vaginal contraceptive rings, it can also prevent bleeding for substantial periods of time. The surgical options to deal with heavy menstrual bleeding, it will be directed to patients in whom the medical therapy failed, or those who have significant pathology. For example, polypectomy, myomectomy. Endometrial ablation نقصد به إنه we are destroying the endometrium, but we should do this after we have excluded malignancy or pre-malignant condition. The endometrium, it can be ablated by a variety of destructive methods such as freezing, heating, applying ultrasound energy. Following the ablation, we should offer the patient effective contraception, as the ablation would cause significant damage to the endometrium, and this will lead to increase the risk of miscarriage. It can lead to increase the risk of abnormal placentation as the placenta pericreta. Hysterectomy, it is the last surgical option when significant pathology is found, example, atypical hyperplasia or malignancy, or when other options fail. You can go back to these references, and thank you very much.